The first speaker, Dr. Ferdinand. Dr. Ferdinand is currently professor of medicine at Tulane University, and he was previously a professor of clinical pharmacology at Xavier University in New Orleans, as well as previously professor of medicine at Emory University. He's a member of numerous organizations, too many for me to name them all here, but I'll highlight a few, and those include the Association of University Cardiologists, past chair of the National Forum for Heart Disease and Stroke Prevention, as well as a member of the Association of Black Cardiologists. I talked with Dr. Ferdinand before this, and both of us are alumni of Howard University. And it was at Howard University he told me he first came into contact with this group, Association of Black Cardiologists. And I think he may speak a little bit about them during his talk. But the Association of Black Cardiologists has an Access to Care initiative where he is co-chair, and this is the Access to Care initiative is a multi-organizational working group targeting disparities in the access of evidence-based medications and devices. It provides leadership and guidance to our National Blood Pressure Initiative in areas of clinical care and community health as American Heart Association cooperative agreement. As I said, he's participated in numerous clinical educational activities. He's very active in his community locally and nationally, working to eliminate disparities in healthcare. And he also has been awarded many different accolades, from the Lewis Russell Memorial Award of the American Heart Association to the Congressional Black Caucus, Health Trust for Journalism, the James Herrick Award for Outstanding Achievement in Clinical Cardiology. He's done many, many more things. I don't want to take up time though, because he has a very interesting presentation, as well as the others that you will hear today. So, without any further ado, I'd like to turn this over to Dr. Ferdinand.
Thank you, Keith. That was very generous. If I will be allowed to share my screen, I'll move forward. And a lot of the comments that I'm going to be make will also be amplified by other speakers, some of whom are personal friends and colleagues. But I'm going to focus on practical approaches to eliminating the disparities that Dr. Emmons has just detailed. We're going to discuss some evidence-based tactics to address the disparities which have just been detailed. And we're going to propose some ideas on what we can do to better control hypertension, which I think is the most potent and prevalent. You look across the landscape of driving disparities, specifically in the non-Hispanic Black community. Here's life expectancy. The bottom in the orange or light brown is the non-Hispanic Black life expectancy. In the middle, you see the majority, and at the top, you see Latino Hispanic. What you're looking at is the persistent and unacceptable white-Black mortality gap. Although there's been a gradual increase in longevity, Black adults in the United States have shortened life expectancy compared to white adults, and it's been persistent for decades. The rest of the story, although it narrowed a little bit around 2015, is post-pandemic, life expectancy has dipped for all, but more so for the Black population and Hispanic Latinx population. So any protective idea of being Hispanic Latino has been lost in terms of life expectancy, and the white-Black mortality gap has gotten worsened. Now, there are many causes for heart disease. One of the things that we can address is the LDL cholesterol. This is a linear relationship. Higher LDL is seen over to the right. Coronary heart disease go down as you start to lower the LDL cholesterol with statins. It's been a consistent, linear, and direct relationship. The problem is, for the last several decades, probably because of a lot of misunderstanding and downright miscommunication, even persons who have atherosclerosis, who have diabetes, who have markedly elevated LDLs of 190 in the green, which is a surrogate for familial hypercholesterolemia, when you look at those populations, the percentage of them who are actually on statins, as would be recommended, is very, very much less than what we need to see. The rest of the story is if you look at Black adults who are prescribed statins, who have these various conditions, diabetes or atherosclerosis at high risk, across those populations, the Black patients are less likely to be prescribed statins. So that's one of the things we can do, is intensively address statin therapy in those high-risk patients. But let's go to hypertension, because I think it's the most potent and prevalent of all the risk factors. Over half of Black adults have hypertension. It's among the highest in the world. And there are a lot of reasons for it. I don't think it's driven by genetics, by the way. It's mainly adverse social determinants of health, where people work, live, play, and pray, lack of access, health-seeking behavior. And some of that health-seeking behavior is because there's a lack of trust, mistrust, or downright distrust among many in the Black community, especially older Black persons. And it's not just because they're uninformed, but some of it's on the basis of historical discrimination, and that plays a critical role in non-adherence. Most of you know the numbers. Hypertension at one point was 140/90. We changed it to 130/80 based on observational data in the SPRINT trial that showed that lower is better. But if you go back to that 140/90, it no longer is the cut point for hypertension, but it defines stage 2 hypertension. At that level, your risk for a heart attack or stroke has doubled. Now, it's not enough for us to just do screenings. We have the Healthy Heart Community Prevention Project in New Orleans. For decades, we've gone to beauty shops and barbershops and churches and supermarkets and sporting events. But doing screening is not enough, because if you look at the level of awareness across the populations, it's high. Even in the Black community, awareness is high, even treatment is high. Where we fall down is control. A lower percentage of these patients are controlled. So if we're going to do outreach, we have to tie it into appropriate therapy, or we're not doing the right thing. I showed you life expectancy was taking a dip for all populations. Some of that is going to be driven by an uptick in cardiovascular mortality, which has been predicted. We now know NHANES, in its latest determination, had already shown a downward trend in blood pressure control. But then the most recent data that postdates the NHANES, Medicare, Medicaid commercial data, showed that downward trend has even worsened. So time does not equal progress. We're not doing better in terms of controlling hypertension, as I mentioned, the most powerful and prevalent risk factors. So we can then predict that we are going to see an increase in cardiovascular events in the near future. Now, what about out-of-office monitoring? I think that's really going to be a profound leap forward if we embrace empowering patients through shared decision-making, teaching them how to get a device which is validated and use it appropriately. What's overlooked is that it's a class 1A evidence if you go down to the 2017 high blood pressure guidelines. Now, this is before the pandemic. The experts in that panel had already suggested that out-of-office blood pressure was beneficial class 1A evidence to confirm the diagnosis, to titrate medicines, and they were really prescient. They said it could be used in conjunction with telehealth. So more and more, we're seeing a move towards out-of-office blood pressure. Another thing that we're starting to embrace is that the magic 15-minute visit seen by a primary care provider every 3 to 6 months is probably not going to be adequate. In fact, it is not adequate to control a chronic condition that a person lives with 24 hours for the rest of their lives. And in fact, that 3 to 6 month visit is only adequate for a person who has stage 1 blood pressure, which is now 130/80, and also has low risk. Once a person has stage 1 hypertension and their 10-year risk is greater than 10%, they need to be seen on a regular basis until the blood pressure is controlled every month. And if that person has stage 2 hypertension, remember the cut point was 140/90 for stage 2, stage 1 was 130/80. But if they have stage 2, then they need to be seen within a month of the diagnosis, and when medications are changed every month thereafter. This is directly out of the guidelines for adults initiating new or an adjusted regimen for hypertension. Adherence in response to treatment at monthly intervals until control is achieved. Now, this does not necessarily mean it has to be a comprehensive physician visit, but some touch point with that patient until the blood pressure reaches adequate control. One of the things that we had done in medicine for decades, we would go to big conferences, the American Heart Association, American College of Cardiology. There was previously an organization known as the American Society of Hypertension. I was the vice president. And at these big Congress, doctors would get up and argue which medicine was better than which medicine for hypertension. Well, here's the truth. Most adults, middle age and older, especially Black adults, it's not really an argument of which medicine. It's going to be a combination. 2 or more antihypertensive medicines to achieve these more intensive goals are going to be necessary. In fact, the Million Hearts, you're going to hear a lot from Dr. Sperling, the director, has actually suggested that we use fixed dose combination as a first step in many patients in order to control blood pressure. And they have a publicly available publication, which is going to be updated soon, in which you can go to your state and look at those fixed dose combinations which are available under Medicaid for disadvantaged patients. Those fixed dose combinations then becomes an appropriate way of first step management. Another thing that they're doing is looking at those success models. One is the Kaiser in California. There still is a difference, white versus Black, but their levels of control are much higher than in many conventional practices. And what Kaiser has done is start with a combination. Their combination is an ACE inhibitor, thiazide, lisinopril hydrochlorothiazide, in some more difficult to patient, chlorthalidone, and then they add the amlodipine. So you end up on a difficult to treat patient, thiazide type diuretic, RAS inhibitor, lisinopril if you have a nuisance cough or angioedema, maybe an ARB, and then a calcium channel blocker. You're going to hear more about the barbershop study later. I was a consultant. The principal investigator was the late Ron Victor from Cedars-Sinai in Los Angeles, but the rest of the story is Ron actually is from New Orleans and was a longtime friend of mine, and I consulted with him as he moved from New Orleans to Dallas and then to Los Angeles on how he could make real some of the promises of the community-based intervention using barbershops. And what he did was, the barbers didn't treat the blood pressure, by the way. He used a combination of the barbershop, a specially trained pharmacist embedded in the barbershop who had prescribing abilities and could communicate electronically with the physician at Cedars-Sinai, and had the patrons in an environment where they felt comfortable. The other thing is, Ron had discussed 2 drugs as the first step. Now, Kaiser uses a diuretic with an ACE inhibitor. He actually used amlodipine with either irbesart and telmisart, which is an angiotensin receptor blocker. It really doesn't make a big difference when you look at the data. If you combine a RAS blocking agent with a diuretic compared to a calcium channel blocker with a RAS blocking agent, you get similar blood pressure effect. For the thiazide type diuretic, he used indapamide, which is somewhat similar to chlorthalidone. And for the aldosterone antagonist, he used eplerenone. You're going to see these data later. I will not go into great detail, but I will tell you these were patients with real hypertension, starting at about 152 to 154, intervention versus control. And in the intervention group, they got 90% of them less than 140/90 and 2/3 less than 1/3/80. Very robust blood pressure control in a difficult to treat population. This is an editorial that I wrote for Circulation. The editors of Circulation said that they wanted me to comment on what I thought was the secret sauce of the Los Angeles barbershop study. So here's what I did. I made a Venn diagram. Improved hypertension control is the middle. And I suggested several things. First of all, let me reiterate, the barbers didn't treat the blood pressure, but the barbershop was a trusted site for intervention. So hopefully all of our care centers, whether it be a barbershop, faith-based community interventions, or the regular clinic, patients are felt to be comfortable, wanted, and needed, and will seek care. So that's the barbershop, a trusted site of intervention. Number 2, it wasn't doctors who were doing the real work. It was specially trained pharmacists. Pharmacists, nurse practitioners, physician's assistants, using appropriate algorithms can actually control blood pressure just as good, if not even better, than physicians. But of course, it's the team. Those advanced practitioners can collaborate with doctors. And then finally, Ron, as I did, always suggest is one of the reasons we don't do well is because patients are so adverse to medications. And he knew the data that two-drug therapy was going to be the way you control blood pressure that's in the guidelines. And he suggested that we start with two-drug therapy and be not afraid to use a mineralocorticoid receptor antagonist. For those of you who are not clinical, those are agents that block some of the agents that come out of the adrenal gland across the kidney that are associated with more severe types of hypertension. Now, if you want to mimic this, either using the barbershop approach or the Kaiser approach, there's some simple pathways to do that. One is try to use once daily combination pills. Even if it's not a combination pill, recognize that most people are going to need 2 or more medicines. I struggle with my community to get over this idea that medicines are bad. Medicines are not bad when used appropriately at the correct doses. Shared decision-making medicines can have a profound effect in terms of preventing heart attacks and strokes. I didn't want to give short shrift to lifestyle modification. We know that there are several studies looking at China and Peru in changing sodium load. There's a study in the southern part of the United States called REGARDS, in which they looked at what causes some of the high blood pressure disparities that we see in the South, where I'm located. And they actually describe what's called the Southern diet. You know it when you see it, high in saturated fat, sodium, sugar-sweetened beverages. They felt that that was one of the hallmarks of an increase in blood pressure in that population. So medications, adhering 2 or more medicines in most patients, lifestyle modification. And then the third step is the team-based care. I work very closely with nurse practitioners. Dr. Sperling, who's going to address you later, I know has always incorporated nurse practitioners for decades in his practice. That is the way to go. It's not enough to wait for that magic 15-minute visit every 3 to 6 months to control this chronic condition. Integrating our records, integrated health records, patient registries, telehealth. There's a small pilot study we just completed at Tulane. It's been published. It was a oral abstract of the American Heart Association. We gave patients a blood pressure device, a valid blood pressure device, and then communicated with the patients through texting. Didn't come in to see me. I didn't call the patients. Medical students just sent texts. After 8 weeks, there was an increase in adherence and an increase in blood pressure control, statistically significant, without changing pharmacotherapy. It's because the patients were able to see their numbers, understand their numbers, and adhere to their medications. You're going to hear more from the Million Hearts. This is not a particular study, but this is a simulation in which they predict what would happen if we did 3 simple steps. We could control 80% or more people across the United States with hypertension. Here are the steps. First of all, follow-up time. Remember, in the guidelines, it's suggested when you start, when you change, when you up-titrate every month until you reach control. Intensify medication therapy. Medicines are not bad. Medicines help. If you go back to the 1960s, the VA cooperative studies, patients who were on placebo compared to medication therapy with blood pressures averaging about 160, really significant hypertension. In the placebo cohort, after 2 years, half of them had heart attacks, strokes, or were dead. So when I tell my patients, look, I don't want you to be in the placebo group, we're going to treat your blood pressure. And then finally, work with your patients for adherence. I think the best means to achieve adherence is through shared decision-making, set the goals for blood pressure control, agreement on the medications, agreement that the medications are beneficial. So when you see patients, if the blood pressure is not controlled, intensify therapy and make sure that they're adhering to medications. In the final pathway, though, we're going to have to do what my patient allows me to use his picture. We need to sit down, eye level, culturally appropriate, literacy appropriate level, using pictures and models, show me technique where the patient can talk back to us and encourage our patients to ask questions so that they have what I call shared decision-making. I think that's going to be the final pathway to control blood pressure. Keith, I think we may have time for some comments, questions, and answers. I'm ready to go.
Thank you very much. Excellent presentation. I'll start off the questions because you mentioned several different things. One of the common threads I heard, but you didn't mention, was the stress factor is enough and how one can get over that. Now, you did mention at the end there some of the things that you did, your picture with the patient. What are some other techniques that you could hand out to relieve that stress factor when our patients come in to see us?
That's a great question. Yeah, that's a great question. The reason I didn't mention stress, Keith, is not that it's not important. It is important. It's hard to measure. We do know that if you look at zip code analysis, there's something called redlining. You're aware of it, where in urban areas in the 1930s, 1940s, they would draw a red line around certain neighborhoods in order to say those were not neighborhoods where they were going to give a good rate for home ownership. Those disadvantaged populations, if you fast forward now, you do zip code analysis, have worse outcomes. So we know that where people work, live, play, and pray has a profound effect, but it's often hard to measure and it's not part of the conventional risk factors. So it's something that we have, we should recognize, we should figure out how to measure it better, but it's really difficult at this particular point to ascertain, especially within the structure of the regular doctor's visit, how you assess that impact. But I'm certainly, I recognize what you're saying is true, that it's a profound effect.
We can open up for any other questions. We have the chat that is open also. If anyone has any questions and would like to place them in the chat, or we can open up the microphones for further questions.
Dr. Katrina Taylor from the California Department of Public Health has a question. Welcome, Katrina.
Excellent presentation, Dr. Ferdinand. I just wanted to ask, so, I try to jot down a couple questions so that I can be prepared also when I talk a little bit later to kind of come back and touch on some of your points. But I really like that you started off with talking about access to care. Can you touch upon that just a little bit more now that we're coming out of COVID and the whole idea of rebranding access to care and utilization post-COVID and what that could mean for management for patients?
Certainly. If you look across the populations, the counties that don't have expanded Medicaid, and I know California does a good job with that, but especially in the South, where it's not embraced, the counties where you have high levels of persons who may even be working but not have affordable insurance, that's where blood pressure control is worse, and that's where cardiovascular mortality is worse. In fact, if you look at it in NHANES analysis, not having an identifiable source of care and not visiting the clinic within a year, that's 5 times more of the worst outcomes. It's even more predictive than Black versus white. To a large extent, Black is a surrogate for those adverse conditions.
Hit that spot on. I won't hold it up because I see Hector has a question also. But could you also kind of touch on the idea of out of office management? So I know a lot of people are really getting on board with monitoring their blood pressure at home, but a lot of times their blood pressure cuffs are not calibrated correctly. So is there a way for the physicians to kind of encourage that, or, if they are bringing in their numbers for the physician to monitor, what can they do to kind of encourage the patient to bring that in for the calibration?
Very good. So what we did in our pilot study called Text My BP NOLA, N-O-L-A, which stands for New Orleans, Louisiana, we went to validatebp.org and gave the patients a valid blood pressure device. Unfortunately, it's not covered by many insurances. Some Medicaid may cover it, depends on the plan. But we gave them a valid device. We had them come in and taught them how to actually use it. And then the numbers were Bluetooth back to the clinic so that we could actually see their blood pressure. What I didn't do is bring them in for a doctor's visit and start writing new prescriptions. The patients then became partners in their care and were able to modify their adherence behavior, improve blood pressure control without any change in pharmacotherapy.
I'd like to.
Thank you.
Thank you. I'd like to ask any others in the audience of the methods that they have used to alleviate the stresses and fears that Dr. Ferdinand has discussed, and also what Dr. Taylor has mentioned in terms of bringing in blood pressures and checking blood pressures. Dr. Ferdinand said these are not often covered. What techniques have you used to sort of get around the system that we're encumbered by sometime to improve the health of all of our patients? So I'd like to open that up to all of the participants here. What methods would you suggest that you have tried?
This is Dr. Sky from Travis. I think that I will give an example I have right now. I have an 80-year-old Black woman in the hospital, and the first thing I could tell when she's interacting with me is she's nervous, right? Is she going to trust me? And so you got to have that conversation with the patient. And she told me when she was a child, she didn't feel safe going to hospitals where she grew up if the doctor was white. And so we got through that conversation and we agreed we're going to be a team. And after that, once you have that trust, I feel like you can move forward. I know that doesn't address the socioeconomic status of not having coverage, but I feel like, at least from what I've seen, that getting that trust and addressing their concerns is so important.
Keith, if I can comment, I know we don't have much time, but what he said was so important. Many of you may not recognize that if you backdate segregation, Jim Crow, it was only in the mid to late 60s. So your patients who are in their 60s or 70s, and here your patient was 80 years old, they lived a real life of segregation, discrimination in the South. The trains run from New Orleans up to Chicago, the city of New Orleans, and out to Oakland and Los Angeles. You have a lot of people from Louisiana and Texas in those areas. The older people will be nice, they will be kind, but no, they don't trust Orthodox medicine.
I want to piggyback on that. Dr. Sky, thank you very much for mentioning that. And I cannot emphasize enough for all of us on the call here to please do what Dr. Sky suggested. Openly address it, recognize it, even if, and address it, even if you don't think it exists. Put it on the table, and I think Dr. Ferdinand will agree that this type of open discussion will open the doors to better trust. Are there any other questions?
I wanted to follow up with a question, and I think it's consistent with some of the Q&A we're getting in the chat. You mentioned, Dr. Ferdinand, nurse practitioners as well as pharmacists as key team members to help manage cardiovascular risks. And I know in low-income environments that is not financially feasible for this level of expertise, and nurses in expanded role or community health workers or others have been used by some clinics. I wanted to get your perspective on, given your experience, what level of training or expertise is needed. I do worry about relying on a workforce that may be pretty expensive, and also maybe there's a lot of shortages where we know a lot of medical assistants can relate to patients or people in the community, et cetera. So I'm wondering your perspective on the requirements for team-based care.
So I'm in New Orleans, Final Four, Super Bowls, Jazz Fest, Mardi Gras, you name it. But the people at the bottom who service those wonderful experiences you have in New Orleans, many of them are uninsured or underinsured. We use community health workers here in New Orleans. I have advanced practice nurses. They can be reimbursed through some Medicaid plans. And even if they're not reimbursed, many times it's the touch point that's important. In the Kaiser system, patients can come in for a blood pressure check. It's not billed as a doctor's visit. So if we're really interested in controlling blood pressure, we have to do those follow-ups with the patient. Now, self-monitored blood pressures, if we can get these devices paid, instruct patients, use shared decision-making. I think I've shown in my pilot, there's some other studies out of Minnesota, that this is a surrogate to more frequent doctor's visits, having the patients empowered to control their blood pressures in an outpatient setting, because many times the medicines aren't being taken because there's that distrust, mistrust that we talked about in the past. So they say they need to stop. Let me give my take home before they stop. I think it's important for us to recognize that overall, we're talking about conditions which affect longevity itself. This is not social scientists. This is not wokeness. This is not feel-good stuff. We spend a lot of money on these disparities. 33% of people who are on dialysis for Medicare are defined as Black. And you say, well, why do you care? Because you pay for it. Once they're on Medicare, the disadvantage, it's $90,000 to $120,000 a month, many of them uncontrolled diabetes, uncontrolled hypertension. Heart failure, very high in the Black community, highest rates of rehospitalization. So why do you care? Because you pay for it. Your insurance goes up if you have a private insurance because the hospitals will cost shift to make up for that disadvantaged person who's the frequent flyer coming in. So it's a waste of money, but it really isn't the only reason we do it. It's the right thing to do. We will not have a just society unless we have health equity. And just looking at the numbers, talking about longevity and the white-Black mortality gap, I think is something we need to bring to a halt and curtail it and change it and overcome it.
Thank you very much. I do not see any other questions in the chat.
Okay, so there
someone can
are
see-
some questions in the Q&A there at the bottom. Are you able to see the Q&A, Keith?
No, I don't see the Q&A.
Okay. Well, we have Hector Flores with us who raised his hand. We just promoted him to panelist so that he could ask the question directly.
First of all, I want to thank our Dr. Ferdinand for a wonderful presentation. And, just an answer to Dr. Emmons' question about what ideas are working in other communities. I think you've hit on three areas that we also see as highly essential. Both Dr. Ferdinand and Dr. Emmons really walk the walk of something we always say, that what we do outside the four walls of our office is as important and sometimes even more important than what we do in our office, because we can only serve a limited number of people, but we can certainly be advocates for change. And I would like to ask all of you to, if you haven't heard about the Safety Net Coalition in California that was started by LA Care and John Backus, is to improve payment on the Medi-Cal side up to Medicare levels, to allow safety net providers to have access to specialists who otherwise may not be able to afford to see Medicaid patients in California, as well as supporting the primary care doctors in private practice doing similar work. The second piece is really organizing our delivery system. We talk about practice transformation, the patient-centered medical home, team-based care. Dr. Ferdinand talked about community health workers. One of the key elements of our practice is that team, but also community health workers. In Spanish, it's the promotores de salud, who we ramped up a relationship with Visión y Compromiso through a HRSA grant to address the COVID disparities, the vaccine disparities in particular. But now we have a workforce that can be trained to educate patients on chronic disease, facilitate access, help them navigate the system. And I think that's really of critical importance, very similar to what Dr. Ferdinand did in the study. And the last thing for us is that we have our own independent practice association. California is heavily penetrated with HMO medicine. By the end of this year, 90% of Medicaid patients will be in an HMO. It's important to have those vehicles, but those vehicles allow us to have the resources up front to make the business case to subsidize things like providing patients with blood pressure cuffs and even facilitating transportation, other things that many health plans may not pay for. But if we don't take care of that, we're going to pay for it dearly, as Dr. Ferdinand mentioned. So I just wanted to reiterate what you've done and what we've done in East Los Angeles here in California. Thank you very much for that presentation.
Great comments. Thank you.
Thank you. There was one question in the chat in regards to, has anyone used RNs operating under standing orders? Dr. Ferdinand, I'll let you address that.
Yeah, there is a push for algorithms in which you have a series of steps. That's what Kaiser does. It's kind of what the Los Angeles Barbershop study did. Start with 2 medicines. If uncontrolled, come back in a month, and you may have to increase the dose, come back in a month, add a 3rd medicine. If you look at patients who have difficult to treat or resistant hypertension, it's usually those 3 main medicines: a thiazide type diuretic, long-acting calcium channel blocker like amlodipine, and a renin-angiotensin system, an ACE inhibitor or an angiotensin receptor blocker. Those three medicines come together in order to control these difficult to treat patients, but it has to be done in somewhat of a gradual basis. You don't want to start with three medicines and cause hypotension or unnecessary complications. But medicines work. I'm going to mention also one more thing before we close. In New Orleans, we have a major NHLBI grant called Cherish. We're going to go into the churches, 42 churches, Black congregations in New Orleans, and we're going to use community health workers and nurse practitioners and hold settings in the church, not necessarily doing service, of course, but in the church setting of intervening on blood pressure and cardiovascular risk. It's going to be a heavy lift. I can't tell you it's going to be positive. It's going to take some time for us to see, but we're going to actually see if we can move the clinic out into the community, because it's chronic conditions like this that are just not going to be solved by magical 15-minute doctor visits.
Thank you very much. Now, I'm one last thing. I will take liberty as a sort of the master of ceremonies here to combine a couple of questions. One from an anonymous attendee was, have there been any studies around understanding the social determinants of health needs of the patient that could be a barrier for adherence or impact of outcomes? I think we've addressed some of those, and I think some of that will be addressed by some of our upcoming speakers in a few moments. But I also want to say that we have had instances where things have been taken away. I work for a company now that is the Medi-Cal provider of healthcare services for Santa Barbara and San Luis Obispo counties. I noticed one of the things that the state has done is taken away, in terms of diabetes, the continuous glucose monitoring. So sometimes we give one and we take something away. And we're going to have to, I think, address all of those. You're going to hear some of that in the future. To our participants here today, you're going to hear about some of that in the future. But I think what Dr. Ferdinand, Dr. Flores is saying, Dr. Sky is mentioning, is that if we can combine people that care, whether they be in the church, in the barbershop, any social setting where your patients feel comfortable, if we can address their needs in those locations, we begin then to get over that barrier, the social determinants of health included, of getting that message across